Hello, my name is Eric Heinz. I'm an anesthesiologist at Mary Washington Hospital, and I will be presenting the May 2025 POCUS Case of the Month for open anesthesia. This case builds on the March and April POCUS Cases of the Month. If you have not already watched these videos, I encourage you to do so before viewing this case. You receive a call from the senior surgical resident telling you about a patient. The resident reports a 61-year-old female who was brought to the ER after experiencing 16 hours of severe, sharp abdominal pain in the lower quadrant. Her significant past medical history includes hypertension, diabetes, COPD, and obesity. In the ER, the patient is hypotensive, tachycardic, tachypneic, and is only oriented to self. The surgical resident states the patient has a rigid abdomen and severe rebound tenderness. In addition, the surgical resident placed a right subclavian central line as the attending was making his way to the hospital. Given the patient is requiring increasing vasopressor therapy, the resident is transporting the patient emergently to the OR for surgical intervention and asks that you come immediately to the OR to assist. In the OR, you meet the patient and quickly confirm the basic medical information from the patient. In addition, you place ASA standard monitors and perform an emergency timeout procedure. Then, rapid sequence induction is performed using etomidate and succinylcholine. Direct laryngoscopy reveals a Cormac-Lehane grade 2 view, and a 7.5 endotracheal tube is successfully passed through the vocal cords. The tube was then secured at 23 centimeters at the teeth. Confirmation of endotracheal intubation occurs via chest rise and positive end tidal CO2. Shortly after incision is made, the patient's SpO2 drops from 98 to 95% and then slowly decreases to 89% over the next 10 minutes. In addition, you note the ventilator showing increased peak pressures, approximately 35 millimeters of mercury. Now, despite increasing the FiO2 from 80 to 100% and increasing the PEEP from 3 to 7 and providing the patient with recruitment maneuvers, the patient still remains hypoxemic. In addition, there's no recent chest X-ray. The resident who placed the central line did not order a post-procedure X-ray. Breath sounds are difficult to hear due to the patient's obesity and COPD. And, given the emergency, the background noise level in the OR is quite high, making auscultation of the lungs difficult. Which of the following could cause this clinical picture of slowly onset hypoxemia with elevated peak pressures? A. A blocked endotracheal tube. B. A misplaced endotracheal tube. C. Bronchospasms. D. Pneumothorax, or E. Inadequate paralysis? The answer is all of these situations can lead to relatively slow onset hypoxemia and increased airway pressures. To further narrow the differential diagnosis, focused lung ultrasound is now going to be performed. So let's refer back to our mnemonic that we have previously used in this series, which helps us integrate diagnostic POCUS into clinical practice. As a refresher, the mnemonic is I AIM and stands for I indication, A image acquisition, I interpretation, and M medical decision making. So let's apply this mnemonic to our current patient who is about to undergo lung ultrasound. In this case, the lung ultrasound exam is being performed to narrow the differential diagnosis of the patient's slowly onsetting hypoxemia and elevated peak pressures. Note that in this clinical situation, point-of-care ultrasound is helpful when auscultation is challenging and other imaging modalities are not readily available. For image acquisition, due to the presence of surgical drapes covering most of the patient's body, lung ultrasound was focused on the anterior lung zones. Specifically, a low-frequency curvilinear transducer was placed near the mid-clavicular line between the second and fourth intercostal spaces, with the probe positioned in the patient's parasagittal plane and the probe indicator pointing towards the patient's head. When we place the ultrasound probe in this position on the patient's right chest, this is the sonogram we see. Please take a moment to review this ultrasound clip and apply what you have learned from previous open anesthesia lectures to this sonogram. Which of the following is present in this lung ultrasound? And list all that apply. A. Lung sliding. B. A lines. C. B lines. Or D. The spine sign. The correct answers are A, B, and C. In the coming slides, we will look more closely and identify the presence or absence of each of these choices in our patient's sonogram. Here we can clearly see the hyperechoic pleura sliding on each other between the adjacent rib shadows. This is evidence of lung sliding. In addition, we can see the repeating horizontal lines arranged at equal intervals below the pleural line, and they gradually fade. These are A lines. Note that at this depth we only see a single A line and that it is an equal interval below the pleural line. In the more caudal lung fields, we also note one or two B lines. The B line will be apparent between the blue arrows in this sonogram. B lines are due to vertical reverberation artifacts. They have the following features. B lines originate from the pleural line. They also extend to the depth of the image without decreasing in intensity. And finally, they move synchronously with the lung sliding. Recall that 1 to 2 B lines per rib space is considered normal, whereas more than 2 B lines is considered abnormal. However, in this sonogram, we do not see a spine sign. In the normal spine sign, you see ultrasonographic evidence of the spine at the bottom of the image. This is indicative of a pleural effusion, where the pleural fluid will actually propagate the ultrasound beams, causing an acoustic window, and allows for clear visualization of anatomical structures at the bottom of the image, including the spine. This is not present in our patient. To review, we can see from this sonogram the presence of lung sliding, A lines, B lines, and we do not see the spine sign. Overall, this appears to be normal lung tissue and does not explain the hypoxemia in our patient. In order to examine the lung sliding more closely, you decide to switch to the high-frequency probe. Recall that the high-frequency linear probe is more suitable for investigating more superficial anatomical structures and superficial pathology. When examining the lung in the second intercostal space at the midclavicular line, this is the image that we see. Just as when we scan with a low-frequency probe, we can clearly see there is lung sliding present with the linear probe. In order to investigate the left lung, you decide to utilize the high-frequency probe at the same anatomical site on the left side. This is the image that returns to us. Do you notice anything unusual? There is no appreciable lung sliding present on the patient's left side. You recall that lung sliding can be difficult to visualize in the upper lobes of patients with COPD, so you decide to scan lower in the left chest, and this is the sonogram that we see. What do we visualize here, lower in the left chest? This is a lung pulse, and a lung pulse refers to the subtle movement of the pleural layers that is with the cardiac pulsations transmitted to the pleura through the lung. This results in a very subtle amount of periodic motion of the pleura that correlates with the patient's heart rate. It is best viewed in the lung areas adjacent to the heart. Now, in a normal, well-aerated lungs, the lung pulse is not appreciated, as lung sliding is dominant and masks the cardiac pulsations. However, that is not the case with our patient today. Rather, no lung sliding is evident, and a lung pulse is present. Taken together, these images seem to suggest there is no lung sliding present on our patient's left side. Now let's move on to interpretation of our lung ultrasounds. The views are first interpreted individually and then summated into an overall impression. Recall from previous slides, the apex of the right lung appears to be normal in our patient, which includes the presence of lung sliding, whereas our images on the patient's left side of the lung did not appear to have any lung sliding present. Therefore, the overall impression and interpretation of our abbreviated lung ultrasound exam appears to indicate there is unilateral absence of lung sliding, which is likely impacting our patient's respiratory status. Unilateral absence of lung sliding includes a differential that goes beyond just pneumothorax and includes, at minimum, some of the following: focal absence of ventilation from either a misplaced ET tube or mucus plugging, pulmonary adhesions, and pulmonary blebs. Clinical context is very important when we are interpreting the sonograms and making medical decisions. We know the patient recently had a central line placed, specifically in the subclavian vein, which is known to have the highest risk of iatrogenic pneumothorax compared to other sites for central line placement. In addition, no post-procedure chest X-ray was performed to rule out this complication. However, our lung sonograms show the presence of lung sliding on the patient's right side, thereby decreasing the likelihood that our patient's hypoxemia is resulting from a pneumothorax secondary to central line placement. In this case, there is unilateral lack of lung sliding on the patient's left side. The more likely explanation for this scenario would be a misplaced ET tube, more specifically a mainstem intubation. So once we have interpreted our lung ultrasounds, we then move on to medical decision making. For medical decision making, you decide that mainstem intubation is the most likely scenario causing our patient's hypoxemia, and decide to slowly pull back the endotracheal tube 2 centimeters while closely watching the ventilator and end tidal CO2 tracing. You then place the high-frequency probe back on the patient's left chest and observe the following sonogram. And what do we note now in this sonogram? We now observe lung sliding on the left, confirming our diagnosis of mainstem intubation. The patient's peak pressures decrease and her oxygen saturations slowly improve. So in this case, we used POCUS to diagnose unilateral absence of lung sliding caused by a mainstem intubation. We know that emergent intubations are more likely to result in mainstem intubations, and factors such as short body stature and high BMI are associated with increased risk of mainstem intubations. These factors underscore the importance of careful technique and vigilance during emergent intubations. The use of lung ultrasound has been shown to be a rapid and effective way to confirm proper position of an ET tube. It can also outperform traditional techniques such as colorimetric end tidal CO2 confirmation and auscultation in acute clinical situations such as cardiac arrest and primary trauma survey. Now I would briefly like to discuss M-mode. M-mode has historically been used to assess the presence or absence of lung sliding in the detection of pneumothorax. However, we must remember that there are significant limitations to using M-mode for pneumothorax detection, which we will discuss more in the coming slides. But first, let's briefly look at what we would see in the M-mode with the presence or absence of lung sliding. When there is lung sliding present and viewed in the M mode, we refer to the image we see as having a seashore pattern, where the C appearance represents the skin, muscle, and pleural line, and the shore is the image of the lung artifact with lung motion. When there is no lung sliding present and viewed in the M mode, we refer to the image as having a barcode pattern, where the upper layers of the muscle and the pleural line have the same appearance. However, the barcode represents the lack of lung sliding present. Now, the emphasis on M mode in teaching could significantly impact clinical practice by leading clinicians to over-rely on the pattern, such as identifying a seashore or a stratosphere sign or a barcode sign as definitive indicators of pneumothorax. However, as I mentioned, M mode has significant limitations for detection of pneumothorax. It can produce both false positives and false negatives for pneumothorax. So B mode ultrasound is considered more reliable than M mode for pneumothorax evaluation, basically because it provides a detailed two-dimensional grayscale images that allow for direct visualization of specific anatomical features and dynamic signs associated with pneumothorax. In contrast, M mode generates a one-dimensional, time-based bar pattern that can be ambiguous and susceptible to artifacts and false readings. Therefore, M mode should only be used as an adjunct to assess the presence of lung sliding and detection of pneumothorax. So now I'd like to conclude and give you some take-home points. Lung ultrasound can be utilized to narrow the differential of hypoxemia in our clinical patients. Unilateral absence of lung sliding can be caused by a number of factors, one of which is mainstem intubation. Lung ultrasound is very effective in determining proper placement of endotracheal tube during intubation and has particular utility in acute clinical situations. And finally, M mode has significant limitations in detecting lung slide, specifically can cause false positives or false negatives interpretations and should only be used as an adjunct in detection of lung sliding. This concludes the Open Anesthesia May POCUS Case of the Month. For more of this series, stay tuned for next Open Anesthesia Lung POCUS Case of the Month coming in June of 2025. Thank you.